Welcome to this talk. I'm Dr. Louise Newson, and this presentation is going to be about testosterone for women, which actually is an important hormone for many of us. Before I start, just to disclose any declarations, I don't actually have any financial disclosures. I don't do any paid work with any pharmaceutical companies, and neither does anyone in our organisation. I'm the director of the Newson Health Menopause and Wellbeing Centre here in Stratford-upon-Avon, director of the Newson Health Research and Education Company, which is a not-for-profit, soon to be a charity. I founded the free Balance Menopause app and the Menopause Charity, and I'm a member of the UK Government Menopause Task Force. My one declaration is that I take HRT, including testosterone actually, which has enabled me to work in a way that I never thought I would when I was a perimenopausal woman a few years ago. I just wanted to start the presentation thinking about hysteria, actually. And if we think about hysteria and think about the word hysterectomy, they are connected. And this is a picture of a hysterical Victorian woman who was thought to be actually making up her symptoms in her head. If we think about even in ancient Greek times, it was thought that women's wombs wandered throughout our bodies, causing madness. And hysteria was womb, and then thinking of hystericus, of the womb. And it was also, some people thought it was thought to stem from sexual frustration in women. And it's horrible, actually, horrific almost, to think that in the 19th century, women were thought to have their hysteria treated with vibrators by their doctors to try and relieve this sexual frustration. And looking back in time, I was looking at some pictures of how different women were managed and treated for their hysteria. And it's very undignifying for women. It's really shocking that women could even be managed in this way. But actually, it's not just with history and with time. Since I opened this clinic 5 years ago, I have heard firsthand from lots of women who have been given quite barbaric treatments for their so-called treatment-resistant depression, which has actually improved with the right dose and type of hormones, often with testosterone as well. I've seen a lot of women who've been given ECT, electroconvulsive therapy, and more recently we've seen a few women who have been given ketamine infusions for their treatment-resistant depression. This is a quote actually from somebody who works in the NHS, and she was on HRT, but obviously not on the right dose or type for her. And she did feel so much better when she was finally given testosterone. And she said, most days I feel unable to perform my job effectively. I am unable to concentrate, can't focus, feel unwell more days than not, feel stressed as I cannot do the tasks I previously did. Most debilitating symptoms being anxiety, resulting in loss of confidence and struggling to do a senior management role. I want to hide away, she said. So I'm going to just start the presentation with a case. This is somebody who wasn't called Nadia, doesn't look like this, but it was just to illustrate the patient, who was a 38-year-old lady I saw in my clinic, who'd been diagnosed with cancer of her cervix 6 years previously when she was only 32. She'd had radical treatment. She'd had a hysterectomy, her wound removed, and her ovaries, and she'd had chemotherapy and radiotherapy. Since then, she'd experienced symptoms of low mood, anhedonia, really not wanting to do anything, no motivation, poor energy, fatigue, reduced libido. She'd also was experiencing quite extreme vaginal dryness and soreness, and she was finding it very difficult to sit down for long periods, difficult to wear underclothes or tight-fitting jeans. She'd actually stopped exercising because that was too painful for her. And as I've said, sitting down was uncomfortable. She's sometimes described as if it was acid being poured between her legs, and she'd had recurrent urinary tract infections. She'd been given some HRT by one of her doctors, and she was given some 100 microgram Everol patches. She didn't need progesterone because she didn't have a womb, but it really wasn't helping at all. She'd also been prescribed amitriptyline, the antidepressant, quite a high dose actually, and it hadn't really helped, but she was too scared to stop taking it in case her symptoms felt worse. And a lot of healthcare professionals had just told her she needed to put up with her symptoms. She should be very grateful that she was feeling in the way that she did because she'd had such awful treatment for her cancer. It was probably related to how she was feeling having had cancer. So she didn't really know what to do. What she did decide to do was to download the free Balance app. She logged her symptoms. She looked at which monitored her mood. It could monitor periods, but obviously she didn't have them, but also her sleep and physical activity. And then she downloaded this booklet that I've written in conjunction with others for young women who've had cancer and have had treatment and have become menopausal. Now, the word menopause means different things to different people. And these are some quotes from a survey that we did recently. And it's very sad to think about people being invisible. It's a shameful thing. And then a lot of people just think, well, it's a natural process, so why make a fuss? Now, when we think about testosterone, the studies have been done looking at libido in women, and we know from the NICE guidance we can prescribe testosterone in women who are taking HRT if they have reduced sexual desire. So Freud looked at what is libido, and I'll come to this a bit later on, because it's not actually just looking at sex. And of course, for women, a hormone is not the only thing that's going to improve our sexual desire. We know that obviously our sex hormones have a massive impact on our brain. They work as neurotransmitters, and they work all over our body as well. So they're not just the way that we feel and think about sex, but actually the physical act. We have receptors that respond to testosterone around our clitoris, around our vagina, our vulva as well. But there are other physiological changes that occur that can affect our sexual desire. Of course, there's psychological and interpersonal interactions, how we feel about ourselves, how we feel about our partner, whether we're stressed for other reasons. And also there's a massive amount of sociocultural factors that can affect our sexual desire. And as clinicians, we should be adept in accessing all of these in our patients in a very individualized way. It's not just about hormones at all, but we can't forget the role of hormones, especially the role of testosterone in our body. We have cells that respond to every cell in our body responds to testosterone, and this picture just shows in lots of different areas. We know one of the first testosterone clinical trials in 1940, many years ago, actually was looking at men and women. Really important, and how wonderful there's a female scientist in the picture, and they considered using women. And since then, women have been forgotten, especially when it comes to proper research, but also with testosterone as well. So is it just a male hormone? It sounds like it should be because of the word testosterone, testis coming from the testis. But actually, it's the most abundant biologically active hormone in women. And we produce 3 times more testosterone than estrogen when we're younger. And our levels of testosterone just naturally decline as we age. We have testosterone receptors everywhere, all over our body. And if we look at this slide, a very simple slide, it shows that the pink are testosterone levels and the green are estrogen levels. And we can see that relative to each other, there's more testosterone produced. It sort of peaks around the ages of 24 and then declines as we get older. This is a picture of someone's vulva, and you can see the introitus as well for the vagina, that we've got pink receptors, pink areas of the pink is where estrogen and the blue is testosterone. We've got testosterones all around this area. There's a reason that we have them, and it can help with not just sexual function, it can just help with the how this area stays healthy, stays well lubricated, and obviously very close to our urinary tract as well. And then this is a picture of a brain, of someone's brain has been cut in half, looking sideways on. And we can see there's pink dots are estrogen and the yellow is testosterone. And our thalamus, our hypothalamus, our hippocampus, which helps with our emotions and our memory as well, our amygdala, our stratum, and our frontal cortex, really, really important areas that in the brain that helps with neurotransmitters. It helps with different hormones as well. So estrogen and testosterone help working with other hormones. So our dopamine, our reward centers in our brain, our stress hormones, our cortisol and adrenaline, all of these have biofeedback mechanisms with them. And these hormones are really important. They can also reduce inflammation in the brain and help with all the messaging and the wiring that occurs. Even in the cerebellum, which is our coordination area of our brain, a lot of women find that their coordination is not so good when they're perimenopausal or menopausal. And obviously, they affect the way that our brain works associated with our mental health. And we know for many years in history, there's all sorts of people that have been written about associated with madness. So Bertha Mason in Jane Eyre, Shakespeare's witches in Macbeth. And we know that there's a high rate of suicide in women between the ages of 45 and 54, which is commonly when hormones not only change and reduce, but they're often very chaotic. And our brains like homeostasis, they like everything to be the same all the time. So if any of you have ever experienced being tired or hungover, your brain doesn't work as well. It doesn't like change. And if our hormone levels are going up and down and changing, this can affect our brain in very adverse ways. And we know, obviously, the biological changes that occur can lead to mental health problems. We know that menopausal women are 3 times more likely to report symptoms of depression, and estrogen and testosterone can have very important effects on our brain. So if we look at sex in the menopause, then we know that libido, like I've said before, can reduce to many different reasons. And we did a survey recently asking women, and these are the top 6 reasons why they were struggling with their libido. So vaginal dryness, weight gain, the way that they perceive themselves, increasing fatigue, low self-esteem, anxiety, irritability. And these are the key factors obstructing a healthy sex life. And obviously, stress, children, loss of spark in the relationship, nothing that you would be surprised at. But perimenopause and menopause, a quarter of people questioned said it was directly relating and affecting their sex life. And also, nearly a quarter with vaginal symptoms as well. We know that genitourinary syndrome of the menopause is very common, and it can be more common in women who've had a history of cancer. And it can often be worse in women who have had radiotherapy, chemotherapy, graft versus host disease, and aromatase inhibitors, which are often given to women following a breast cancer diagnosis as part of their treatment, because it strips every ounce of estrogen away from the body. And I've seen a lot of women with really extreme symptoms who are on aromatase inhibitors. And we know, even looking at some studies in oncology clinics, a lot of women were not having their symptoms addressed properly by clinicians. And when the clinicians were asked, a lot of it was because they had lack of knowledge, they weren't asking the right questions. And a lot of people were then referred to a gynecologist, which is good if that gynecologist has had the right training. But actually, any clinician should be able to treat people who have symptoms related to GSM, because it's very easy to treat people in the right way, and no one should be waiting long times to see a gynecologist. We have a lot of resources on our website, and we've written this position statement with the British Society of Sexual Medicine, which is available for anybody to read and hopefully learn from as well. We know in the NICE guidance, which now came out in 2015, they do discuss that we can consider testosterone supplementation for menopausal women who are on HRT who still have reduced sexual desire. And if we look up testosterone in Wikipedia, it talks all about testosterone and how important it is in males. And it even talks about mice as well, and how it's important for looking at studies in mice, of course. But then it's not until after that section it gets on talking about women and say that it may modulate the physiology of vaginal tissue and contribute to female genital sexual arousal, of course. But it's almost thinking that it might be a problem if we have increased sexual arousal. And it's very, for me as a woman, I feel very undervalued, and I'm not sure that I want to be defined as just somebody that may or may not be sexually aroused. So when we look at the symptoms of testosterone deficiency, there's lots of symptoms. It's not just about sexual function. A lot of people find that they have anxiety, low mood, irritability, lack of well-being, physical fatigue, memory loss, muscle joint pains, hot flushes can even occur due to testosterone deficiency. And then we look at hypoactive sexual desire disorder, HSDD. And this is actually a proper disorder, and it's defined as loss or absence of sexual desire, which is associated with personal distress. And it's very common, actually. It occurs in around a third of women between the ages of 40 and 64, and 13% of women aged between 65 and 75. If we look at the diagnosis, the diagnostic criteria, it's really long and complicated. We have to have at least 3 of all these listed, these 6 criteria listened, and then they have to have persisted for a minimum of approximately 6 months. And then they have to cause clinically significant distress. And then we have to make sure that it's not explained by a non-sexual mental disorder. So it's a really big process, actually, to show that you are severely psychologically distressed with your reduced libido as a menopausal woman, which I think is quite horrific, actually, that this is the way women are addressed. Because if you think of male HSDD, actually, they can diagnose it themselves. And if they've got a credit card, they're allowed to get treatment over the counter in the form of Viagra. And this is a real gender difference that really needs to be explored. A lot of women and clinicians are worried about testosterone, and these are very common symptoms about, will I turn into a bearded monster? What will happen to my hair on my head? Will it make my voice change? Will it increase the size of my clitoris? Is it safe? Will it affect my heart or liver? Does it increase the risk of breast cancer? And actually, it's a reassuring no to all of these if it's prescribed in the right dose and the right way as well. It might make the clitoris enlarge, because a lot of women find their clitoris shrinks during the perimenopause or menopause, but it doesn't become absolutely massive in a way that's wrong in any way. People find that they might have voice changes, but their voice will go back to how they were before if their voice had changed during the menopause. And we give it through the skin, so it doesn't get metabolized by the liver at all. This is just an overview paper which shows some reassuring facts about testosterone and reduces any misconceptions. What we don't have is really robust long-term safety data, because the studies haven't been done, but we do know that testosterone implants have been used for many, many years. And we used to use oral testosterone for men and women, but it gets metabolized by the liver, and it can affect the liver in a negative way. So we don't use it orally at all. So transdermal testosterone doesn't activate the liver clotting factors either. So it's thought not to increase risk of clot, and it doesn't affect the liver. And we've got long-term studies from transgender female to male patients, and they have no increased risk of vascular outcomes, mortality, or increased risk of breast cancer as well. And there is some data that testosterone can inhibit estrogen and progesterone-induced breast cell proliferation. And also it can be beneficial on glucose metabolism and lipid profiles, very important when we think about the menopause. And I think this is really interesting that it can reduce amyloid deposition in the brain, and amyloid deposition can be associated with dementia risk. We did a study in our clinic, a retrospective, so looking back at the notes study, and these were women who were already on HRT, who had completed the symptom questionnaire before and after they'd been given testosterone. Now, we've looked at 905 patients, and about half of them had no change in their HRT, so their HRT dose was the same. All we did was added in testosterone. So we did the MSQ, the menopause symptom questionnaire, before and after adding in testosterone. This is the questionnaire. The one on the left is the green climacteric questionnaire, evidence-based questionnaire, that we've modified it slightly, because you'll see number 4 was excitable. I didn't really know what that meant, so I changed it to memory problems. And I added 2 other symptoms at the bottom, urinary symptoms and symptoms related to vaginal dryness. And the results are very revealing, actually. We looked at women who had more severe symptoms, and we gave it for the indication of reduced libido, but we found across the board there were lots of other improvements of symptoms. And actually, the symptoms were more significantly significant than mental health symptoms. So the loss of interest in things, the low mood, the anxiety was more statistically significant than the improvement in libido, which is really important and not surprising when we think about the power of testosterone on our brains. We also found that the proportion who had improvement out of this number, although it was 64% had improvement in their loss of interest in sex, actually loss of interest in most things was the vast majority, and feeling unhappy and depressed. And this is what we see in our clinical practice all the time. We see a lot of women who have been given various drugs, especially antidepressants, even quetiapine, antipsychotics, and they're not feeling much better on HRT. When we prescribe testosterone, it can be really transformational for women's mental health. So the summary of our short study showed that actually restricting testosterone to those women who only fulfill HSDD criteria would actually miss a large proportion of women who would have positive effects on both cognition and mood. And cognition and mood effects were seen across all domains, most pronounced on depression and anxiety, and even less so, but still there for memory and concentration. And the patients who'd had their dose of estrogen increased actually didn't have an additional benefit. So it shows, I think, that we should be thinking about adding testosterone in a bit earlier rather than just increasing estrogen. So going back to our friend Freud, this is what he wrote about libido, and he said it's an expression taken from the theory of emotions. So we call that by name the energy regarded as a quantitative magnitude of those instincts which have to do with that may be comprised under the word love. So it's not just about a physical act of sex, it's about a love for others as well, and humanity, and also for concrete objects and abstract ideas. And a lot of women who are on testosterone just say they have an enjoyment of life. They're seeing things in colour again. They're better with their well-being. They're enjoying going for walks. They're enjoying their family. And these are things that are quite hard to measure, actually, when you look at a scientific study. But this is really important for how women function. And I think it's absolutely horrific that so many women are being denied their own hormone back. When we look at measuring testosterone levels, there's free and bound testosterone, and we usually work out the free androgen index, which is a measure of total testosterone times by 100 to make it a percentage and divide it by sex hormone binding globulin. It's quite a crude test, and we find clinically it's more important talking to the patients than going on absolute numbers. Sex hormone binding globulin can be increased by various conditions, especially oral estrogen can push it up as well. And it can also be reduced by these as well. We often do some bloods if people have got reduced SHBG or increased SHBG, but actually improving lifestyle, especially changing diet, increasing exercise, can actually push up sex hormone binding globulin. So the big question is, who should consider using testosterone? Certainly there's a lot of benefit for those women who have an early menopause, those women who have a medically or surgically induced menopause, especially women who have their ovaries removed, will lose a lot of testosterone overnight. Certainly even the guidance do agree that women with HSDD should be considered for testosterone. But actually, I feel quite strongly about this, that any perimenopausal or menopausal woman who wishes to discuss it can, and maybe even all or most women should be considering testosterone. When we think of preparations and dose, it's very hard because in the UK we don't have a licensed preparation. Obviously, there's a licensed preparation for men, and many other countries don't have a licensed preparation for women. We tend to use Testogel for women, or we use Androfem cream, which is a female testosterone cream which is licensed for women in Australia, and we can prescribe it privately. It costs around a pound a day. So we use a lower dose than obviously a man would use. It's around 1/10 of the dose. So we use a very small amount, usually applied to the skin of the thigh or buttock, and we recommend that people clearly wash their hands after applying and wait. It can take a little while. Sometimes people can take 3 to 6 months to improve once they've been started with testosterone, and it can take a while because the dose is so low. And we review people. We suggest that they have blood tests so we know that they're within the female range. We don't always do free androgen index at baseline if the diagnosis is very obvious. It all depends on the clinical case. When we review people, we usually offer a blood test, and then on we do a blood test annually after. It's not like we have to reach a certain level. If people are feeling better and their free androgen index is still low, then that's fine. But if their free androgen index is low and they're still getting symptoms, we often suggest to increase the dose a little bit and then review. So, as I've said, it's currently off license use for women, but a lot of what we prescribe, certainly as GPs, is off license. There's a massive postcode lottery of care when it comes to testosterone prescribing, because a lot of GPs aren't allowed to prescribe it because it's not on their formulary. There's also a lack of training. So a lot of doctors, nurses and pharmacists don't have the confidence to prescribe testosterone. And also it's quite awful, really. The only way of getting it on the NHS is having the male testosterone prescribed for you, and the insert's all about for men as well. And it's not very convenient when you've got a sachet that you have to clip and just use a small amount of every day. The potential other benefits for testosterone use are huge, actually, because if we think about the effect on our brains, if we think about the effects on our metabolism, on our bones and our muscles, a lot of women find that they exercise better, their muscle strength is better. There is some evidence it can reduce risk of cardiovascular disease and osteoporosis. And we see a lot of women who have been diagnosed with long COVID or fibromyalgia and really improve when they have the right dose of HRT with testosterone. And you can go on thinking about other inflammatory conditions. We see a lot of women with these conditions, even POTS as well, fibromyalgia, chronic fatigue, ME, and really improve so much. It would be wonderful to do more research looking at its potential effect on dementia prevention too. So going back to Nadia, she was given low dose vaginal estrogen in the form of 10 microgram Vagifem pessaries, and she was started on Androfem in addition to her estrogen patches as well. The alternative obviously would be Testogel sachets, and 6 months later she was starting to feel better, but she was still complaining of some localized symptom. So we changed her from Vagifem to Intrarosa, which is prasterone, which converts to estrogen and testosterone in the vagina. And then when she was reviewed, she felt amazing. She felt so much better. And it was really very transformational to see such a young person really change in front of our eyes, knowing that the biggest effect has been adding in testosterone. These are some quotes from women that we've seen in the clinic who have been given testosterone. And we hear these stories a lot. Very hard to measure quality of life, but we need to address it even more. And this is just a quote from somebody to when she came back. She was saying how she's very active on her social media groups. And she said, I spread the word to ensure no one has to struggle like I did with not knowing what was wrong with me. So this is all about choice as well. I'm not saying everybody needs to be on testosterone or take testosterone or prescribe testosterone, but we need to know and remember that it is an important hormone for many of us. And so I'm hoping this short presentation has just given you some food for thought and help you consider what testosterone does for women. So thank you for listening.